My apologies, gentlemen. I'm just going to switch this back. And then I will. There. That's going to be a little easier for me to see what I've got up on my screen. Okay. Thanks, Vic. I think I've got full control here now. So thanks, everybody. Really appreciate the invite to speak with you all this evening. I am, even though my history is in cancer research and I've been doing it for a good long period of time, I'm by no means a prostate cancer expert. I have PhD and postdoctoral training in medical oncology, so I have a fair bit of training in cancer treatments and the study of novel cancer treatments. But I was thrilled to be able to do this because, much like my teaching exercises at McMaster, going through the history of a given topic often affords us insight into the pluses and minuses of that history and where we can go moving forward. And so that's what I'd like to walk everyone through tonight. Some of it's going to be quite academic. I apologize. Many of you obviously are very intimately familiar with prostate cancer treatments, obviously. And I don't want to minimize any of that for anybody. So some of this you may have already seen in previous presentations by other doctors or other presenters. But it's always fun for me anyways, as an educator, to walk through the actual history of why we treat cancers, particularly for tonight, prostate cancers, the way we treat them. And so I've given you a bit of an introduction about myself. My story with Illumacell is worth telling because it's one of those sort of 6 degrees of separation where a mentor of mine who is a retired, very successful entrepreneur, I look up to him greatly, almost like a father figure. And he was helping me with my own entrepreneurial activities in doing cancer counseling for patients as well as academics and startup companies who want clinical exposure. And he called me up one day to join him for lunch, oddly enough, with a company that was presenting to him as an investment opportunity. And he said, Jeff, I need somebody who's a cancer clinical specialist to sort of sit in on this lunch and give me whether this is valid techniques or technologies or not. And so, being a former student for most of my life, we were always very well known at not passing up free lunches. So I said, this is a great opportunity. And so that's how I ended up meeting Illumacell proper and Michael Ben, the president of Illumacell. And I sat through the luncheon, and then reported back to my mentor privately that I actually thought that the technology was phenomenal from the standpoint that it's natural and non-invasive, and it's something we could push forward in the clinic, and that I would be very, very thrilled to work alongside either my mentor as an investor or with Illumacell proper. And that's led to 3 years at Illumacell, getting some pretty substantial clinical traction and excitement around getting our light device, our photodynamic light therapy device, into the clinic. Oh, we're not moving forward here. Why aren't we moving forward? I seem to be stuck. Froze. There we go. So I put this slide up not to bring the group down, especially on a day after Family Day, but more just to highlight that basically what I've said already is that there's been decades of cancer research and all kinds of therapeutic advances in all solid tumor treatments, but a lot of patients still end up with terminal diagnoses. And these stats are from the American Cancer Society, and they just highlight that by the time it's 2040, just by the simple fact of our better technologies and we're better nutrition and we're living longer, there'll be greater than 16 million deaths simply due to cancer in general. And those numbers are just not acceptable for someone like myself or anybody for that matter. And that's why we need new treatments. We need treatments that can complement the existing treatments that seem to be the pillars of cancer therapy, but we also need to break free from those pillars of cancer therapy because they're very toxic. And I'll be referring to these often in the talk, those being surgery, those being radiation and chemotherapy. So when I walk the group through the history of prostate cancer treatment over the last 100 years, and I'll promise to try to go through it quickly. I really just want to outline before I get into it how it creates roadblocks for innovative companies like Illumacell. And there's decades of mouse modeling that rarely translates into human successful studies in the clinic. Those pillars I was talking about, they're still the frontline pillar treatments for most cancers, including prostate treatment. And the other thing I wanted to mention before really diving in is that obviously to everybody, we're talking about the male, and I'm going to say female here, cancers of the reproductive system. And so these are not only well known today at the cellular level to be hereditary and genetically linked. So the female, like breast cancer and prostate cancer, are actually genetically linked. This is founded research. It makes sense. There are several subsets of genes that can be mutated in both men and women. And the manifestation of this is prostate cancer in men and breast cancer in women. And as you're all well aware, this is a very socially and psychologically sensitive subject. And so there will be words that I use or phrases that I use that are, again, are not meant to minimize what we're all going through. It's just meant to highlight that these are important organs, and saving them is really or should be the main goal of most therapeutics. So let's get into the history. Can I just ask Vic, is the gallery blocking some of this presentation, or is it okay for everybody?
It's okay for me.
It's fine for me.
Okay, it's just that my gallery is blocking some of it, but that's okay. I just wanted to make sure for the group that we weren't blocking out parts of it.
You can minimize the back gallery.
Okay, as long as it's okay, I'm just gonna.
That's just on your
okay.
screen.
Just be my screen, I can deal with it. So this is very typical of the history of all cancer therapeutics for solid tumors in particular, in that in the 19th century and early 1800s, all the way through the 1800s, we're usually crediting anatomists or sketch artists and early doctors for their groundbreaking work in describing, and in this case, the prostate gland. So Nicola Massa and Andreas Vesalius, these are two individuals in the early 19th century that really describe the prostate gland itself. And Andreas Vesalius is somebody who, I don't know if anybody in the group has seen Bodyworks, but Bodyworks is an exhibition of anatomy, and they plasticize full anatomical human figures and put them in positions that are normal everyday life positions. It's actually stunning in as well as being a bit disturbing, but it's an incredible exhibition. If you ever get the chance to see Bodyworks, I highly recommend it. But I consider Dr. Vesalius the godfather of Bodyworks, because if you ever have the chance to look back at some of his sketches from the 1800s, what he drew and the positions he put his bodies in for the anatomy lessons he was teaching his students and peers are incredible. And both of them, in my opinion, are considered the father of modern anatomy, not just the identification or description of the prostate gland. And both these fellows are amazing in their own right way back then. To move forward through the 19th century, surgery was all there was for prostate issues. Prostate cancer itself at that time was considered very rare and wasn't described till a little bit later, but it was basically in the 18th century and through parts of the 20th century considered a death sentence. There wasn't really much that could be done. And the surgeries, as you can imagine, were radical. And in the 20th century, these surgeries became more specialized. And as I mentioned earlier, the reason being is that there was a significant need to preserve penile functions. The nerves, the other organs, the bladder, the rectum, all around need to be preserved. And Dr. Young at Johns Hopkins, as early as 1904, was the founder of what became the radical prostatectomy, which is obviously now something we're trying to get away from, but is still done. And you can see this huge gap of time between when Dr. Walsh, who really is revolutionized prostate surgery back in 1983 with what is known as a retropubic or sort of a semi-radical prostatectomy. And he basically saved the penis without compromising cancer outcomes. And that was a huge benefit to the surgical standard in treating prostate cancer. And then later on in the 80s, combined with computer techniques, guided ultrasound really became the standard for treating prostate cancer with surgery. This is a bit of a busy slide, but the real point here is that unlike most of the other solid tumor historical pathways of development for treatments, prostate cancer started to use hormone therapy very early in the 1940s. And these were chemical interventions. Dr. Higgins and others later on in the 60s and the 70s were getting Nobel Prizes for this work. It was chemical castration, if you will, or being able to block the hypothalamus, which is responsible for releasing certain hormones that start to activate the prostate gland proper. And we've got basically the regulation of testosterone through a lot of these hormones. And so there's a lot of treatments that involve, these are called androgens, a lot of treatments that involve ablating them or getting rid of these androgens or hormones. That can either be done with castration, it's still done today, or the use of estrogen, which is the female hormone that blocks testosterone. And then back to the hypothalamus, so you can use receptor blockers. And there's a lot of work nowadays in non-steroidal versions of these receptor blockers that are quite effective. But you can see here that they're still met with a lot of severe side effects. There's a lot of cardiac toxicity with hormone therapy, and unfortunately, most patients regress. And with the actual receptor blockers, there were hot flashes, loss of libido, impotence, but then you didn't get the cardiac events. So there was pros and cons to both of these hormone type treatments. Almost to the 90s, medical researchers and the clinicians decided, well, we have to combine these. Maybe if we combine them, they'll be better. And it never really amounted to anything. And that's why the new non-steroidal therapies continue to be better options for prostate cancer patients moving forward. Radiation therapy was actually started very early on. I had the privilege of studying at Princess Margaret Hospital in Toronto at the Ontario Cancer Institute for my doctorate. And I worked with some of the pioneers of radiation therapy and radiation imaging. And it was incredible. But back in the, I'm not back to the 50s, but back in those days, these were therapies that were extremely toxic to normal tissues. They were effective at getting rid of some of the tumor cells around the prostate, but they damaged a lot of the nerves and adjoining organs and systems. And so while these were used in the 50s, brachytherapy being an internal radiation therapy where they actually radio label and implant small radio labeled, back then it was big radio labeled implants right next to the tumor, and then allowed that to just basically destroy the tumor. This started to decline because of the hormone therapy, that the hormone therapy was working very well early in the 1900s or the mid 1900s. And so they started to stop radiation therapy, but it came back. And Dr. Hummel actually was responsible for creating smaller implants or smaller radioactive bombs, if you will, and guiding them with ultrasound and computer technology. And is still, this is now one of the newer treatments, old and new. What was once old is now new again, because they're using it in studies for localized disease. External beam therapy and radiation is exactly what it sounds like. Very toxic, cobalt sourced, intense, and pretty much in the 40s was only used as adjunct therapy. I highlight adjunct therapy here because I'm going to use these terms later on. And if the group's not familiar with what an adjunct therapy is, it's really just something that is either in combination with an existing therapy or in support of an existing therapy. And so at this time in the 40s, that was paired obviously with surgery through the history of prostate treatments. Lost interest with the discovery of hormones, just like brachytherapy at the time, and regained interest later on when better cobalt sources were found. Similarly, computers really advanced radiation therapy, still used today. Obviously, as I had a brief introduction today, from one of your new members there. You can't talk about prostate cancer without talking about the development and the discovery of the prostate specific antigen. PSA, as we all know it, kind of in the 80s is when this was really first isolated and discovered, late 70s, early 80s. Originally, it was an antigen found in semen, and really the original studies of PSA weren't for prostate cancer, but for improved fertility, and then early on for rape victims. So it was purified first as a prostate antigen by Dr. Wong in 1979, but originally studied as a forensic marker, which isn't surprising. But later in the 80s, two doctors mentioned below there, Dr. Padsidero and Stammy, were kind of credited with not just quantitating PSA in the blood, but actually applying it as a PSA test or a marker for prostate cancer. And tumor markers, even today for other solid tumors, are very, very hard to use. And so this became, it really changed the way cancer researchers and oncologists treated tumors, particularly prostate cancers, because now they had what they felt was like a hook or a tether that they could track while they were treating. And it's still used today, even though there's debate about whether it is truly prostate cancer specific. We now know in the clinic that we cannot determine the aggressiveness of anyone's prostate cancer by using PSA, but it does help with the detection of relapse. And even in the 80s, what they called PSA velocity can be a sign that there is cancer there or early detection. And what I mean by velocity is the speed at which these numbers can change in any one patient. Oh, really? So here we go. So this is, I am not going to go through all this. This is just to illustrate how complicated the PSA story is in the human body and other mammals, and why it's not necessarily the best marker, but it is still has application for prostate cancer treatments. It's actually a part of the family of callicranes. And the callicranes originally in humans were thought to just contain of 3 proteins, which was really odd to the scientists and biologists at the time, because all other mammals have dozens of these families of proteins related to each other. And this is what complicated PSA isolation early on in the 80s and complicates isolating it for tests, because they actually did find, as this diagram is simply showing, there are dozens of KLKs. PSA is known as KLK3, not just 3. And again, as I kind of mentioned this on the other slide, it's still used today. There's still debate about how cancer specific it is for the prostate condition. It cannot really determine the aggressiveness of a cancer, but it can help with detection of relapse. And it's still a very important historical moment in treating a solid tumor like prostate cancer, because it basically landmarked that you can use biological markers to help track and treat patients. So chemotherapy is the last one of the pillars, and many patients respond to androgen therapy, which is hormone therapy. I just wanted to put that at the beginning, but the problem with it is that recurrences often develop, or the prostate tumors tend to become resistant to the hormone therapy. So chemotherapy was introduced to try to help with that problem in the 50s and 60s. It really wasn't until 1972 that Dr. Gerald Murphy, who really is arguably the godfather of the PSA test proper. It was his lab at Roswell Park in Buffalo, in upstate New York. It was the people in his lab, Dr. Wang and fellows, who discovered PSA as well as developed the test. But he's also very well known in his career for being the early adopter of single agent chemotherapeutics, or alkylating agents. And he was able to show that 10% response rates in stable disease were attainable with these single alkylating agents as early as the 60s. Many of you are aware that there are newer chemotherapeutic agents out there that are much better than the older ones, and they're still used today. And one of the main uses is in combination with PSA levels. And we use a drop of 50% in your PSA levels as a good response to chemotherapy. So combination therapy is really where Illumacell starts to fit into this story. But I really just want to talk about combination therapies as something that was very important in my career. It wasn't that long ago that most cancer researchers and most oncologists believed that there was a silver bullet to cure cancer. One drug, one treatment will do it. And it wasn't really until probably 40 years ago where we started to 30 years ago where we started to realize that that's just not the case. All of these treatments, as they're being developed through the history of time for cancer, for prostate cancer, for breast cancer, probably need to be combined and determined which combinations of which treatments as a cocktail work the best. And so right now, again, I am preaching to the choir here, but there are currently many combinations of surgery, hormone therapy, radiation. These are all standard of care for prostate cancer treatments now. And again, I just want to highlight Dr. Walsh's work earlier, his surgical revolution of not removing the entire prostate gland if it could be saved, plus radiation, very standard right now. Early detection methods with computer ultrasound guided and PSA levels combined with the surgery and radiation. All of these amazing, amazing landmarks in the history of treating prostate cancer. And you can see how long it took, literally between the 70s to the mid 90s, where 3 times as many men were being treated with these combination therapies. The death rate in men younger than 75 fell for the first time in almost a century, which is, when I was doing this research for this talk, was surprising to me. But it's getting better. It's not a death sentence anymore, but it is a long track of medical advancements over almost more than 100 years. And this, I'm not going through everything I just talked about again. This slide is just to illustrate how basically from the late 1800s right up until now, a lot of these first therapies for prostate cancer fell in and out of favor all the way along because of the inventions and the innovations of other therapies, as well as just getting better therapeutic agents themselves. So really the highlight here is radiation. It was going on in the early 1900s, but fell out of favor because of the hormone therapies, and then came back. Radiation came back in the 60s, and then even in the 80s with better hormone therapies. So really this is just put up here to illustrate that over 100 years of clinical advancements in treating prostate cancer really led to the solidification of 3 pillars of treatment: surgery, radiation therapy, and chemotherapy, or some combination thereof. But there are lots of new studies being performed right now in the clinic for new therapies, and you guys maybe have heard of some of them. I just wanted to say again in review, prostate cancer is still, even with all the advancements, is still the second most common cancer that afflicts men. That sounded odd to me when I first read that, because the prostate gland is only in men. So why wouldn't it be the first or the most common cancer? Skin cancers are still more common, even though skin cancers aren't usually reported. The registries for skin cancers, for some reason, globally, are not as comprehensive as other solid tumors. And so skin cancers are often left off the board when you're comparing, what's the most common cancer in the world or the most common cancer in men. So that's why that seems a bit odd. But current therapies are effective, but there are still side effects affecting quality of life. And we still need new treatments. Cryotherapy is very self-explanatory. That's in the works right now. Brachytherapy is back, where you're placing these small radiation bombs near the tumor. Fell out of favor in the 50s, as I described, but now is back. And we use ultrasounded guided light. Looks like I'm doing some drawing here by accident on my slide. Sorry about that. Here's new treatments, slide number 2. There's high intensity focused ultrasound, which is actually in our own backyard. It's a company called Maple Leaf, and it's HIFU. It's called the Cleveland Cancer Clinic. It's in Toronto. Maple Leaf, when I first looked into this, it'll be interesting to talk after I'm done this presentation to those who maybe have experienced this or have opted to use this very new therapy that is a very highly mechanized treatment bed with a rectal probe, and then there's an operational table that's connected to it digitally so that the clinical operator and oncologist control this probe that releases high intense ultrasound waves to destroy all the way around the prostate gland. It's called Ablatherm. It's trademarked by HIFU, by Maple Leaf. And then there's photodynamic therapy, which again is kind of where Illumacell ties in, and where I'd like to tie in by walking you through the history of prostate cancer treatments, why some of these new treatments are better from the standpoint of being more natural, less toxic, but still effective. And photodynamic therapy, for those who are unfamiliar with it, is light therapy, but not just plain light by itself. It's light therapy plus a photosensitive drug plus microenvironmental oxygen near or in the organ. And those three things combined, when they come together, basically create cell death and tumor cell death. The last 10 to 20 years have seen some early stage prostate cancer studies in PDT, but they weren't reviewed very well or received very well due to the fact that they use a lot stronger proprietary drugs and very weak lights. Illumacell has stronger lights, and I'll get into that one. Last 4 slides coming up about Illumacell and our technology. And so the other downside to the early photodynamic therapy for prostate cancer treatments is the use of fiber optics or endoscopy. So it's invasive. We have to use fiber optic probes to get deep to the prostate gland to treat it locally. So enter Illumacell and this exciting new company that I've been working for the last few years. What do we offer? What's our solution? We basically can offer cancer patients, prostate cancer patients included, a non-invasive natural way to use light therapy. It can actually be done on most solid tumors because of the advances in the light device, and not just early stage. A lot of the work in the new treatment sort of sections that are being performed right now in prostate cancer are all in fairly early stage cancer. We can treat all stages. This breakthrough technology allows deep penetration of light into the tissue without having to do surgery. And so much like the HIFU type of highly mechanized treatment device, we could potentially become standard equipment in all hospitals and treat a wide variety of tumors. This is basically what our prototype looks like. It is a series of control packs and a LED display control panel that allows us to control the intensity of the light, as well as the heat that's being dissipated through the light. There's a chiller attached to this light as well that you can't see in this picture that keeps these thousands and thousands of high intense LED lights from basically burning. So this is what it looks like. And this is what we've used in the clinic a few times already. Here's our typical clinical protocol that we would use. And again, it illustrates the 3 components that PDT needs that Illumacell can provide. 5-ALA is our natural prodrug of choice. It is a natural amino acid that everybody's cells make. We all make it. We just give it to the patient orally in so higher doses than your body would make. And what we have found is that most tumor cells aren't very good at metabolizing it out, whereas your normal cells metabolize it quite quickly within 4 to 6 hours. And so we give the prodrug orally, it accumulates in the tumor. The prodrug gets changed into the photosensitive molecule in the tumor. We shine our magic light on it, and the light activates that photosensitive molecule and causes tumor cell death. This, apologize for the graphic image, but this is an example from Illumacell's treatment in a private clinic in the Hope for Cancer Clinic in Mexico of a stomach tumor. This was in a patient's stomach, and after light treatment with our Illumacell PDT, we are able to basically necrotize completely the tumor. It's all necrotic, it's black, it's basically gone. And this patient had a successful removal of their tumor without having to do surgery and without having this toxic side effects of radiation or chemo. So next to last slide, except for just some acknowledgements. This is really the summary slide, which is what are the advantages of Illumacell PDT? And I think I can be honest and say it's not just Illumacell PDT. PDT in general and some of these other new treatments for prostate cancer. What are our advantages? Well, the main one is that we're promoting natural and non-invasive treatment. We, unlike the competitors, we use a strong light and a weaker photosensitizer to minimize these toxic side effects. No surgeries required. We can go deep into tissues with our therapy, which means we can get to deeper tumors. And we have very quick clinical recovery time. What's really exciting to me, honestly, as a cancer researcher, being in cancer research for as long as I have, is that this type of therapy, the PDT, is exciting as a neoadjuvant therapy, a combinatorial therapy, as well as an adjuvant therapy. So the neoadjuvant therapy is really what gets me excited because that's the last point. Illumacell PDT has a significant chance of altering or paradigm shifting first-line cancer care. We would really like to see PDT become your first choice while you're waiting for a diagnosis, while you're waiting for a surgery, while you're waiting for radiation. There is no reason why you couldn't have a light shined on you for a while, once or twice a week for a few hours, and we can paradigm shift first-line cancer care because we know we can shrink tumors with PDT and others have done it. And so prostate cancer treatment, PDT could be used, as I said, for first-line treatment, specifically for non-androgen ablative approaches. So anybody who doesn't fall into that treatment bucket, PDT could be used. It could easily be combined with radiation or even replace it. And it could be very effective in androgen-resistant prostate cancer treatment. So those patients falling into that bucket, PDT could be effective there. It doesn't rely on hormone therapy whatsoever. So here's kind of our small senior management team. Got to know these fellows very well, and we are all working well together and working hard to try to get this off the ground. We've got a fair bit of clinical experience already in the 2 years that I've been largely doing the clinical track work for the team. And this is just references and resources that are a part of the presentation. So when you guys go back to this presentation and save it, much like you did your others, you can go to these links. I highly recommend going to them if you want primary articles to read on basically what I've reviewed with you guys tonight. They're here, and I kind of titled them for you so that you know where these references will take you. So really, that's all I have to talk about tonight, and I open up the discussions in a roundtable format. And thanks so much. It was a pleasure being able to share some of this with you. Hope it wasn't too academically boring.